Yes.
Yeah.
And this is Miles. For those of you who haven't met him, I think most of you have met Miles at this point. So,
Hi, Miles. Nice to see you.
was
All right, should we let folks in, Lindsay?
before we do, did
Oh,
we?
wait.
Was there?
Yes.
Was there? I didn't see any like applications or anything we were supposed to review in advance.
Correct.
Correct. Okay. Phew. Thank you.
Hey, Tom.
Hey, good afternoon.
I know. I think we have a quorum. I always forget what the number is for this committee. So let me look at the number.
We're expecting 5 out of 6, but I believe the quorum is 4 out of 6.
Quorum is 4, I think, yeah. Because we have 6, right? So I think we have, who are we not expecting, Lindsay? Just so.
I think Kristen knows who's not attending today specifically.
Jesse
Okay.
Hammond declined and
Okay.
wasn't able to make it.
Okay, so
Thanks,
we
Kristen.
have, thanks, Kristen. We have Kate O'Neill, Tom Walsh, Josiah Reich. Is that how you pronounce your name wrong? Right? Wrong. Right.
Yeah, you're good.
That's
Carry on.
to be me. It's 4. So we have a quorum, right? We're just waiting for Lowry. I don't see him. Okay. Why don't we let everyone in, Lindsay? Did you let folks
Okay.
in? Okay. Then we'll get started.
Oh, yep. Wes, Greg, and Lowry are coming in.
Oh, great. Just pull up the agenda. Okay. See, Wendy, and we. Okay, I think we can get started. Good afternoon, everyone. Welcome to today's Green Mountain Care Board Data Governance Council meeting. It is August 19th, 2025. We have a full agenda. The first item on the agenda is some chair's report, and I will be welcoming some new folks to the Green Mountain Care Board. I see Wendy is here. I don't see Emily here. I'm not sure if she can join, but I have some staffing updates that I'll review with you. So recently I moved into a new position at the Green Mountain Care Board. I'm now the Chief Operating Officer. And with that, we have hired on a new executive director. Her name is Emily Brown. And as I said, I don't see her on the call. Do you see her, Wendy? I don't see her. Okay. So I'll just give a quick intro for Emily. She most recently was at the Department of Financial Regulation as the deputy commissioner, and she was there for I think 10 years. So she has a long history in insurance regulation and healthcare regulation broadly. She is a lawyer and really brings a lens of that experience at Department of Financial Regulation, if I didn't spell it out, DFR. And again, looking at the insurance market and also broadly the healthcare regulation in the state. So we're really excited to have her. With that change in the executive director, we wanted to take back take some time and look at the charter and potentially update that charter for you all. And then at the next meeting, we'll discuss some of the changes we're proposing. The other exciting addition to the Green Mountain Care Board is we've hired on a new director of data, and her name is Wendy Geller, and she's joining us today. So I'll have Wendy introduce herself, which would be a lot easier than me talking about her extensive background.
Very kind, Susan. Hi, I'm Dr. Wendy Geller. Most recently, I have spent a little bit of time in the private sector over the last couple of years, working as a consultant at the federal and the national level. Before that, I served the Agency of Education as their first chief data officer type of a role. And yeah, it was great. My particular areas of expertise are modernization, data strategy, organizational change, transformation, and data governance.
Thanks, Wendy. And welcome. Okay. Any questions from the council? Or anything else that staff wanted to add? Okay. Oh, actually, and I do see a new member of our team. While we're on this introductions, Kirk Williamson is on the call. He is a new addition just yesterday to the Green Mountain Care Board. So Kirk, maybe you should just say hello and tell us a little bit about your background. Sorry to put you on the spot, but I think you can handle it.
No, I'm happy to. Thanks for letting me crash. No, I'm happy to. Thanks for letting me crash your meeting. Affordability and pricing here at the Green Mountain Care Board. I most recently was the executive director of the New Hampshire Prescription Drug Affordability Board. I spent about 10 years in DC. Prior to that, I worked at the National Governors Association for a number of years, the Duke Margolis Institute for Health Policy, and then Arnold Ventures, which is a national philanthropy focused on a number of issues, but I focused on drug pricing reform there. So great to be here and work with all of you, and thank you for letting me observe.
Thank you, Kirk. Welcome as well. Okay, so the next item on the agenda is the approval of the June meeting minutes. And for folks who hopefully you got a chance to look at them, they're on our website under the June 3rd meeting. So folks want to take a look at those, and a motion would be welcomed.
I'll move to approve.
Second.
All those in favor? Aye.
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 Okay, great. The June meeting minutes have been approved. Thank you. The next item on the agenda is the review of public comment regarding data reporting, manual changes, and recommendations to defer vote. I believe I turn this to Lindsay Kill, Deputy Director of Data at the Green Mountain Care Board.
Hi, thanks, Susan. So actually the next 4 topics on the agenda, I have all in one PowerPoint for us. So I'm going to try to set this up. Let me see if I share my screen this way. Can you see just the screen with my PowerPoint on it?
I do.
Okay, thanks. Sorry, this is the first time I'm running it from a SharePoint site. Anyway. Technology. All right, well, thank you all. So for today's meeting, I gotta click. I can't use my keyboard. Noted. We have 4 topics that I'll be walking us through. Lots of opportunity for just conversation, discussion around all these different issues, but I'm just going to be laying them out for everyone. I think hopefully I got the right order on the agenda and the order here, but we have 4 main things to touch on. The first is data reporting manual changes review, the public comments you received and our recommendations. The next is the new executive orders from the federal government and how they impact our data in the APCD. We're also going to talk about some Data Governance Council charter updates to align with our data governance rules at the GMCB. And then the last is just like an overview of data use agreement process challenges we've been having at the GMCB and some of our recommended approaches. So I'll just go ahead and dive right in. So at our last meeting, we presented the data reporting manual updates, proposed changes, and those updates included the addition of non-claims payment extracts to the APCD. Those were for the commercial submitters only, and there were 3 proposed files: an annual file, a capitation file, and a pharmacy file. Per the rule, we heard 30 days of public comment, and then the DGC could vote thereafter to move to accept the data reporting manual changes. And then we, the GMCB, would have worked with OnPoint, our data vendor, to implement those changes for submitters. We received 2 public comments during the 30-day public comment period from our commercial submitters, one from Blue Cross and Blue Shield, which stated that the pharmacy, both of these are up on the website. It stated that pharmacy rebate information is confidential per their contract with Optum, and it also cited that there are operational difficulties with implementing this. We also received a public comment from AHIP, which requested that the non-claims payment extract updates and any future data reporting manual changes be done by amending Rule 8 through the formal rulemaking process under the APA. They also cited some operational difficulties. And we did, in the 30-day public comment period, we did have to clarify with the submitters that the DRM changes that we proposed on June 3rd only applied to the commercial submitters, as that is who was involved in our initial submitter engagement plan that took place this winter. Medicaid or DVA required a different timeline for the development of their non-claims payment collection and extract creation. So the submitter engagement there is not complete. So the data reporting manual changes, again, that we reviewed back in June, do not apply to Vermont Medicaid or DVA at this time. Again, so per rule, the DGC has the option to vote to approve the changes to the DRM now that the 30 days have passed. And GMCB staff recommend postponing the vote for now so we can have more time with commercial submitters and our Medicaid submitter to discuss the challenges and opportunities for alignment. The GMCB staff, would be using this time to gather more information from the submitters, and we would bring this information back as we learn it, as well as the in-depth analysis of the NCP requirements for state and federal reporting. It's not going to let me click back. Hold on. Stop sharing here for a second and undo that. So any questions about the data reporting manual? Oh, yes.
Yes,
Josiah.
I have one. So there were a few changes in the draft where the focus of the, was the concern just with pharmacy rebates, or were they with the other areas that had changes as well?
Great question. I would say that there were concerns with the other files as well. Yeah, so pharmacy and with the other files.
Okay. So then, as a follow-up to that, are you thinking that you would work with the commercial folks and then do another round of proposed changes with another public comment period, or what's
Absolutely.
the next step? Okay.
Yeah, we would be redoing the process. We'd be re-engaging submitters, re-interviewing, doing a more detailed engagement process, And we would be recollecting that information, and it would, per rule, have to go through the whole process again. New public
Thank you.
comment period and all. Yes, Kate.
Thank you. Could you explain a little bit more about the comments that you received from AHIP? I guess that's the Trade Association for Health Insurance Plans, regarding their recommendation that the changes take place within the rule itself as opposed to the data reporting manual.
I can share, I can color some of it. I don't know if I can exactly explain their letter, and I don't know if anybody on the call today is from AHIP. We didn't receive any further communication from them. It was just that one letter, and I did send out, I think, a few communications, like all submitter communications. I didn't get anything additional back, but when I read the letter, I thought, I was not sure if what they were recommending is that we go back to the old way of doing things, right? Because we worked, GMCB moved data reporting manual specifications out of rule for this reason, to make it more well, among many reasons, like to help make it a little bit more nimble and be responsive to the reporting needs over time as they come up, because amending rules is time consuming and non-trivial, I'll use that word. So I'm not sure if they were like looking at the old language about where it was in rule, making changes to the data reporting submission guide was in rule, or if they were suggesting that we move it back into rule.
Thank you for that. That's you explained it precisely as I understand it too, and that's why I brought it up, because it doesn't sound like the staff is recommending that we revisit the rule and make changes there. But right, we years ago, the effort was to pull reporting specification out of rule in order to facilitate changes in the future. And I wouldn't recommend, I wouldn't want to be interested in returning back to adding the specificity into rule. So I didn't know if there was an effort underway to, I didn't know if you thought maybe the comments there deemed it necessary to review, or if it seemed you're just bringing it up as a public comment. That's what I was curious about.
Yeah, just bringing it up as a public comment. We
Okay.
didn't have any response for that, because I don't think that that's the direction we want to go in. Yeah, Susan.
Thank you, Lindsay, and thank you, Kate, for that clarifying comment. And that's how I understand it too. I have two, I have one question and then one just process question. Would it make sense to reach out to AHIP and to further clarify, or do you feel, I guess you, Lindsay, feel like you understand it, we understand it to mean what you and Kate were just discussing?
Yeah, we did ask legal about, do we need to reach out and respond directly to every public comment and like engage a conversation with every public comment? And it was decided that we didn't need to do that.
Yeah.
We certainly can, especially now. I mean, assuming our recommendation is adopted and there's no vote today, then yeah, we certainly can reach out to AHIP and hear more from them about why they would like us to put it back into rule and what maybe they're hoping to gain from that process. Maybe we can meet, cover some of their concerns with this next round of re-engagement. They
Yeah.
did also cite, like, in addition to, we prefer that this is in rule and follows a rulemaking process, that they did cite other like operational difficulties, which, from a technical standpoint, I don't agree are operational difficulties, so we didn't address those.
Okay. Well, I think we can take it offline with the staff and decide what to do next. And it is, you know, they could look at the recording as well and reach out to us as well.
Yep.
Thank you for that. And then process wise, I was just looking on the website. The next meeting is when? Do we have that up on the agenda yet? I'm just thinking would it be like the next meeting we would vote? Was that the plan?
No, I don't think so. The last time we
Okay.
did this engagement process with OnPoint, it spanned from, I want to say we kicked off in January or February, and it went through May. So
Okay.
this is
Yeah.
many
Thank you.
months. So it will not be at the next meeting.
Okay, great. Thank you, Lindsay, for your work on this. I think Josiah has a question.
I do. I have another question. So looking at the letter from Blue Cross, it's, I guess, is there a path to getting this data in a way that addresses their concerns? Because their concern seems to be it would put them at a competitive disadvantage for this data to be available, which feels
Mhm.
like a very systemic concern about like the entire thing rather than there are technical things we'd like you to resolve. So I guess I'm just wondering, like, is there another, like, I guess, what is the shape of the changes that you would expect to come back with that could resolve these concerns? If it's really like, we just don't think you should do this at all, type of an issue.
That's a great question. I think we have some Blue Cross people on the call here today. I'll take a stab at answering that and then let them answer as well, if that's okay. We've had lots of great meetings and conversations with the Blue Cross and Blue Shield team, which I just want to say I'm very thankful for. They're very responsive and they've given us a lot of detail and a lot of really thoughtful feedback. I heard in those meetings that they do recognize the, from a health systems research perspective, a public health stewardship, cost stewardship perspective, all of the mission and values of the GMCB, why non-claims payment data is really important to have in the APCD. They did cite, really, we were getting down to like some technical difficulties of categorizing and summarizing the data. I do think that those can be overcome. And we could get something from them that is both like coming in on a regular cadence so that no one from the state side is asking Blue Cross and Blue Shield or any commercial submitter for ad hoc, on the fly reports on non-claim spend. But the state's getting what they need at a regular cadence, and it's a methodology that everybody agrees on. It will not end up being what is outlined in the APCD CDL version of the NCP structure. But I think so far the conversations that we've had is like, that's an okay direction to go in for, GMCB is comfortable departing from that structure. And Blue Cross has been very understanding. So I'll stop there and I'll let Blue Cross add anything that they want to.
Hey folks, Greg Bobo with Blue Cross Blue Shield of Vermont. Thanks so much for having this meeting and for giving us a little bit of time to talk. We really appreciate it. And we certainly like working with you as well. So as a general matter, I think the overarching concern that was cited moments ago about this data in large part, if not almost entirely, belonging to Blue Cross Blue Shield of Vermont, and the threat that this sort of data might come to arise with respect to placing us at a competitive disadvantage is accurate, and it's a concern that we've had for quite some time. And I think with respect to the new proposed data manual changes, those concerns are heightened even further. I'm not sure, frankly, how those concerns can be alleviated if the proposed changes are not in some way changed. With respect to the technical changes that we cited, I do think that, you know, if we work together, I'm certain that we could probably come to some kind of resolution on how those problems can be addressed. I have I think Wes is on this call, who might be able to address some of those concerns. But it's true, the bigger question is, how do we avoid this competitive disadvantage that you raised? And I don't have an answer to that right now. Maybe if there is a change in the scope of requested information, that might resolve the problem. But I would invite an opportunity to have more in-depth conversations with your staff so that we could potentially overcome these issues.
Thank you. I appreciate that. Would the concerns be alleviated if, for example, this were used for internal research and analysis and not in the, not provided to researchers? I'm not saying that that's necessarily an option, but just like, would that address the concerns?
That's a great question, and I think that would probably go a long way at addressing the concerns. I certainly don't want to commit to anything right now without speaking to other folks. But it's those types of solutions, I think, that might get us to some more comfort.
Thank you.
Hi, this is Wes from Blue Cross, and I just want to briefly talk about the technical side. And I think Greg put it very well, that we have a very good working relationship with Green Mountain Care Board and with OnPoint, and I have no concerns that we can't find ways to make the technical side work.
Thank you both.
Thanks.
Guess back to you, Lindsay.
Hey. All right, well, if anybody thinks of more questions, just jump in, because like I said, this is a very discussion-based meeting. So yeah, so the next topic is the executive order on Medicare data.
Sorry.
Yeah.
Do we need to take a vote to give you another, until the next meeting, to come back with another recommendation, something along those lines? Was there a voting item in that last one? No? Okay.
I would, Julia, you can weigh in here. I don't think we need a vote, but I'll defer to Julia.
Yeah, no, I agree. We don't need to take a vote since we're just postponing.
Cool. Thanks.
Great question though. Thanks.
Thanks. Yeah, so the next topic is the Medicare executive order on affecting Medicare data. We've received Medicare files in the APCD. And this change is to those Medicare submission files. So there are 3 changes. So I'm going to go through the 3 changes and then talk a little bit about each one and the level of impact that I think that they will have on the APCD. So the first change is that CMS is replacing the variable name in the file of gender with the term sex, and the options are going to be male, female, and other. So M, F, and U. The second change is that they are removing race and ethnicity variables from the submission. And the third change is that they are removing the record of all individuals whose date of death is prior to their eligibility record start date. So I'm going to go over what those are in detail and their impacts. Any questions about just these three statements before I?
Is there an executive order number we can go look at in the Federal Register while you're going through this?
Oh, great question.
We
There
can
should
find
be,
out. Yeah.
yeah, but I don't have it off the top of my head. Let me, I think, someone from OnPoint is on the call, or they were earlier, but maybe they're. OnPoint is who notified us of these. That's why I was asking if they were on the call.
I think Kate is on.
Yeah, I'm here.
great.
I
Hi.
I don't have a hi. I don't have it off the top of
Mhm.
my head, but I will look for it and put it in the chat.
Okay, thank you so much,
Thank
Kate.
you.
Sure.
Thanks.
Yes.
Okay, click. Okay, so the impacts to the APCD for, again, like for health services research, for the GMCB's work, et cetera. So item number one, the change of the naming convention of that variable from gender to sex, and those three options for what can be in the fields, male, female, and other. Right now, the GMCB is saying that that will not have an impact on health services research or the files, anything that the state is using, mostly because actually a lot of researchers do already do that. It sort of depends on the payer, but the naming of gender versus biological sex, depends on the submitter and how they collect the data, but it's not an uncommon thing to rename that variable. So I don't believe that that will have any impact on like the outcomes of any of the studies that are being done with the data. The second change, I made a table to this effect, but which is on the next slide, but the second change does impact all Medicare records. It removes race and ethnicity data from all but a small portion of, so it impacts all Medicare records, sorry, and effectively in the APCD removes race and ethnicity from all but a small portion of commercial data, meaning we will not have usable race and ethnicity data at the all payer level in the APCD after this change goes into effect. And I'll show you that on the next slide. And the third change of removing the records for individuals whose death date comes before their eligibility start date. Medicare is arguing that this is a data quality check. We plan to get more information on this and have a meeting with OnPoint about this specifically. But my hypothesis is that from a technical perspective, this will potentially pose an issue for understanding why members lose eligibility for Medicare, which will impact all of the downstream analytics for prospective or retrospective attribution for Medicare. That is a mouthful. So I'm happy to talk about that more or answer questions, or if there are none, I can just go to the next slide. Yes, Susan.
I think we talked about this offline, but maybe you could use an example. Like, could this impact some of the reporting that we'll be doing on the all payer model that we'll have, we're continuing to do even after the model ends, obviously.
Yeah. So for the all payer model, for example, for ACO settlement, for the Medicare ACO settlement, we attribute beneficiaries to the ACO through Medicare prospectively. So it's as of January 1st of the performance year, in this case, 2025. For the Medicare population specifically, there are many ways to, it's called churn off of Medicare. You could be eligible for Medicare in a calendar year and then opt for Medicare Advantage, or you end up receiving the plurality of your care over in New Hampshire and not in Vermont. So then you're a Medicare beneficiary living in Vermont, but you're not getting your care in Vermont. So suddenly you come out of the population for scale settlement. Also, members who pass away at any point in the performance year, or in the, we call it performance year, calendar year, same thing. If they pass away in that time, then suddenly all of their claims history up between the start of the year and when they pass away, that is no longer attributed to the performance of the ACO for purposes of settlement at the end of the year. This is just one example. It is the all-payer model, but again, it's just one example of how we think about Medicare alignment and attribution and the impact of being able to track that data over time. What will happen here, what I'm concerned will happen here, and what we're still working on verifying with OnPoint, is that if every new research file comes in and the person passes away before their eligibility start date, right? So if I pass away in January, my next eligibility start date would be February if I hadn't passed away. So suddenly I'm in the January file, but I'm not in the February file. Why not? We used to have both files. Oh, they're alive in January and they're eligible. Oh, they actually passed away at the end of January, just before February. So they're no longer eligible because they passed away. We're losing that visibility. If I'm interpreting the executive order correctly, we're losing that visibility into why someone's churned off of Medicare. This could have a lot of impacts on how we think about Medicare eligibility and how we track beneficiaries over time, I think. Yes, Josiah.
I just wanted to flag, as you're looking at this, there was a change in how the Social Security Administration figured out whether people were dead or not a couple months back, where, because some cultures don't assign a particular birth date, the way that they were flagging that in the system was to use, I don't remember the details, but something like a birth date in 1850, and then just providing a birth year. That was so you could tell what year they were born in, but didn't know the exact birth date, and they used that to flag that. And the Social Security Administration, at least for a while, had determined that anyone over 120 years old was no longer alive. And so that would be another potential population to look at in here if those folks are getting flagged as having deceased when they aren't, and if that would have trickle through impacts to this file. So that's one. And then the other one, the executive order, the first one, the sex to gender change. I'm with you that it's not a huge change, but I think it is worth noting in our data that, because I think it's worth noting in the data that was a change, because I think that for some providers that may have some data quality implications.
Yep, absolutely. So this next slide, I am just showing the counts for race and ethnicity records from the APCD as they exist today, or as of the date I ran this, which I think was August 1st, covering cell size of less than 11, the old-fashioned way. Does anybody remember when in school, when you had a projector with a Xerox, and your teacher would try to hide the answers by putting another Xerox on top of it with the blacked out? And Wendy remembers. She knows. Okay, I'm not just saying. Anyway, that's what this reminds me of. So here's what we're looking at. So what I looked at here was by commercial and Medicare Advantage submitter, Medicaid, and Medicare fee-for-service. How many it's member months. I'm pretty sure I counted. No, I counted individuals here. Counting individuals, any record at any part of the year for these submitters. And we had, I think it's 2 race variables and 4 ethnicity variables. I might be getting those numbers mixed up, but there's 6 options. So no usable data means that all 6 variables empty or like says, you know, -1 or a -2 or a U, which is like not usable, right? Some data, so some of it's populated, and then all the data. So they had at least one and a race and at least one ethnicity usable, calculable, can actually be like useful in an analysis. And this is what it looks like today right now. So for Medicare fee for service, these are the only years I did back to 2020 through 2024. So Medicare fee for service, because this column here where it says some data, all of this will be going away, which means all that will be left in terms of some data on race and ethnicity is commercial data, because we won't have anything from Medicare and we already don't have anything from Medicaid. So that's where that will put us there, which I know is a huge setback for researchers. Yes, Kate.
Yeah, I was going to say that. It's a setback. And so I have a question, and a comment. I'll start with a comment, and that is that I do believe that the UVM College of Medicine is very keenly interested in using race and ethnicity data from VCures in some of their research. And so I don't know if you have spoken with them directly yet, but maybe that'd be a good idea, just because it seems like it'll certainly impact any efforts that they're doing. I don't know how successful they are, because I know that the data is not great. The question, though, this leads me to my question, and it's that a couple of years ago, the data reporting manual changed to require that race and ethnicity data be reported if it's collected. We did not require the collection of it, but if payers were collecting the data, they were required to report it, and there were dozens of race and ethnicity fields that they were to use. So I guess my question is, would they still be required? Are they still required to report it if it's not going to be in the data anymore? I don't know. Or because I thought I heard you say that this is going to affect commercial data as well, even though it's Medicare data that will no longer be submitting the race and ethnicity data. Is it still collected for commercial data? We'll just have so much less of it.
Yeah,
That it's okay.
correct. Yeah, we just have this little bit of commercial data that's available to us.
I see.
But that's a good note to follow up with UVM specifically. So I will make sure to do that. Any other questions about these changes? Okay. Again, we can always come back to things if you think of things later. So switching topics, we wanted to talk about the Data Governance Council Charter. We are in the process of transitioning the Vermont Uniform Hospital Discharge Data System to GMCB. We've always been the stewards of the data, but previously VDH handled the work of the collection from the data, the collection of the data from VAHHS NSO, and doing all the data quality checks, preparing the annual hospital report. And so we've been in the transition of that process for a while now, on the technical side and the project side and all of that. And doing this work, we realized that the charter, so this is a quote from page 4 of the charter, is not in line with the rule. So we are just wanted to bring this to everybody's attention because we would like to change the charter and update it. So it says here that this charter and the data governance efforts at GMCB are primarily focused on VCURES data. So that's the all payer claims database. In the future, practices similar to those used for governing VCURES will be applied to additional resources at the GMCB, including VUDs. But from Rule 8.401, which I was reading, in relation to VUDs, it's about how the Data Governance Council may revise or modify the VUDs reporting manual. And this is going to sound very similar to everything we're going through at the data reporting manual for VCURES right now. So prior to approving any revisions or modifications, the council will send each affected submitter, in this case, it would be the Vermont facilities submitting to VUDs, notice and a copy of the proposed revisions or modifications. The board will also post notice and proposed revisions or modifications on its website. The council will accept public comments on the proposed revisions or modifications for 30 days from the date of posting, and will review and consider all comments received before approving revisions or modifications. Reads just like the other section on VCURES. So, and there are more sections like this where it's referring to how the Data Governance Council may revise or review changes to all things VUDs. So, so we are, what was explained to us is that we will need to obviously share this change with you, that the rule is law, so that supersedes, is that the right word? The charter is just more of like an internal policy, but the board, the Green Mountain Care Board would vote to approve the charter change. So we would just have to collectively agree to change that sentence and any other applicable sentences in the charter where it says just VCURES basically, and have it also include VUDs, and then update the sort of scope of work, if you will, for the Data Governance Council. So the Data Governance Council would then start hearing data governance issues around the VUDs data asset as well. Any questions or concerns?
This is Josiah again. Are there any data sets that the Green Mountain Care Board manages that the Data Governance Council shouldn't have, shouldn't be involved in?
Should not, you said?
Yeah.
Josiah? Yeah.
That's a good question.
I can, I don't know if I'm going to help here, but I can jump in and say that there are a lot of data collection, data sources, databases that the Green Mountain Care Board manages, holds, collects, like think all of the data that the Green Mountain Care Board receives from hospitals during the hospital budget review process, right? All of the financial data that's required by July 1st of each year. The Data Governance Council is not involved or engaged in that data collection or the quality of the data and that sort of thing. The Data Governance Council, as I understood it, was established to help the Green Mountain Care Board staff be the stewards of the two main healthcare databases that's VCURES, our all payer claims database, and VUDs. And I will say, Lindsay, over in the past years, staff have brought VUDs questions, issues, concerns to the Data Governance Council, but it was always really more of a sort of a secondary kind of database, less complex than the VCures database. And so it's true, you're right, that I think the charter was designed with the stewardship of VCures in mind. From the time of its inception over the years, there was an effort to sort of bring together the operations, make similar the operations of both of those databases. And so when we modified the rule for data reporting, we made VCures and VUDs much more similar than they had been in the past. So I think that making some technical changes to the charter makes sense at this point in time, and it's really kind of another step in that process. This is a long-winded way, though, of getting back to you, Josiah, to say I think that the board collects a lot of other data.
That's right.
But the council is not, specifically, we don't have oversight directly of those. And that doesn't mean it couldn't change in the future. It doesn't mean it's not, but that's, this council was established to oversee VCures and VUDs.
Thank you. Yeah, the reason I was asking was whether we could have it be broader and just say, data sets under the purview of the council, and then not have to worry about saying VCures and VUDs everywhere. Something along those lines. And if it was just data sets managed by the Care Board, the Green Mountain Care Board, sounds like it can't be that. But anyway, that's where I was going.
Any other questions from the council? I think Lindsay has one more topic, right, Lindsay?
Yeah.
This is a great discussion.
Yeah. Okay, I'll go on to the next topic. So the next topic is data use agreement process challenges. We as a team, staff, and with our legal team talked about, whether or not and how much to bring this up with the Data Governance Council, but ultimately landed on this is a huge piece of the work that we do with data governance, and want to share some of what we are working on and some of the process challenges and what we think are solutions, just mostly to keep you all up to date with how this actually unfolds once DUAs are reviewed and all those next steps come about. So right now, today, a data use agreement is a contract per the state of Vermont contracting guidelines, meaning, among other things, that it's subject to some boilerplate language around certificates of insurance and indemnification. These two areas of our contract for the DUA process they're repeatedly an issue for nonprofit entities such as universities who are applying for DUAs for VCures data. So therefore, the net effect is that every DUA application from one such entity, which is most of our applicants, they are research universities or research bodies, nonprofit research bodies, require enormous administrative burden for the GMCB and the requester, because it ends up in this legal contracting battle around indemnification certificates of insurance. And it can take months. I've seen it take as long as a year. What we wanted to talk about, so we sort of outlined that, is potential changes and where we think maybe that would interface specifically with the Data Governance Council, and also get everybody's thoughts on it. So the first change, which is done already, is updating the data release website to more clearly spell out that this is a contract process and that there are contract limitations for the requesters. So we made it very clear on the website that if you're requesting to amend the DUA or not have to comply with any part of the DUA, that is automatically, you know, that can't happen. We can't consider that. It's part of what we have to work with at the state. And then the next thing is updating. We are trying to update our limited use data set to be pre-generated and minimize possible modifications. This is in progress. The reason for this is because related to this sort of the contract piece of the data use agreement. Today, right now, what's happening is an organization enters into a DUA. It's with the GMCB, it goes through PAT review. And then following PAT review, it gets signed off from us, Medicaid, if there's Medicaid data in there, and then it goes to our data vendor OnPoint. The GMCB holds the contract with OnPoint for this work for all things related to BCures. And the requester, so this other entity, non-state entity, ends into a statement of work with OnPoint that they pay for. So OnPoint has a fee for generating the extract, and it gets passed on to the requester. But the GMCB holds the contract. So it puts us in like a very sort of interesting position as the holder of a contract, but it's not our statement of work and we're not paying for it. But we do have, as part of our mission to make these data available, we do have some interest in like, is it affordable? Is it accessible? I see your hand, Kate. I'm just gonna finish this and then I'll come to your question. So one thought we had was instead of a limited use data set being generated for every DUA, creating one limited use data set that is just the one available for researchers as like a base, and that we are paying for OnPoint to generate. And then if there's modifications to that, then at least we've eliminated the base fee of like the initial generating of the limited use data set. Yes, Kate.
Thank you. So I think that proposal needs some thought. If a university or a nonprofit is applying for a limited use data set, they have to comply with minimum use standards and they have to ask for specific data. So having a pre-prepared limited use data set might not comport with that. So just that's something to think about, but it's certainly, I think, worth kind of trying to think through to make it easier on the Green Mountain Care Board and also on applicants. The thing about it being a contract is really just the reason that it goes through the contracting process is to make our data use agreement enforceable.
Exactly. Yeah.
It's not, though, we do ask for a statement of work in their application, but it's not a contract. It's not a contract between the Green Mountain Care Board and another entity for work on behalf of the Green Mountain Care Board. And so in that way, it makes it different. To me, it doesn't seem concerning that a data use agreement would go through the contracting approval process, and then upon approval, the data recipient works directly with our contractor to establish the data transfer and the payment mechanisms and all of that. I'm not a contract expert, but it seems like because our purpose is for, you know, is just for enforcement. And there's no dollars exchanged between us, you know, between the Green Mountain Care Board and the entity. And they're not doing it on behalf of us. I feel like that probably isn't a problem. I love the idea of making the website more clear. And so you got like 2 thumbs up from me on that.
Yeah. Thank you.
And Josiah had some good comments in the chat.
Yeah, I can
Oh,
say them
great.
for the record. So I was just thinking, you know, if the contract vehicle is really only for making the DUA enforceable, do they really need to be 2 separate things? Can we just wrap the DUA in the contract language by stapling the standard contract page and a half to the front of it, and whatever the standard terms we attach to the end of it, and just like handle that as a single thing? It wouldn't change the process, but it would mean that the negotiation process would be a little bit more straightforward, I think.
Mm-hmm.
But I think that language is right in the DUA though. So I don't think it's like 2 things coming together. I think it is a boilerplate data use agreement that that gets signed as if, you know, it's under contract.
I see Dr. Geller has a hand up.
You can just call me Wendy. So something to just kind of also set the table with all this is that you know, the Care Board is a small organization, and while obviously we have responsibilities to make sure that we can make good work happen and research happen, we have to really start to balance those with the time, effort, and energy that it takes out of the staff here to facilitate that work to happen. So do expect some additional conversations about what the business process change for all of this will look like. And you know, Kate, you're absolutely right that boilerplate is very much upfront in any kind of request. And so the website adjustment that we're going to be executing on, and I actually think Ravi has already updated some of the verbiage there, is really just to draw folks' attention, requesters' attention to, you know, hey, this is what the process looks like here in the state of Vermont. We're not in a position to adjust anything in the boilerplate section. So please do consider that before you submit your request. So just going forward, do expect a few more of these conversations about what future state is going to look like, and you know, being mindful of what the capacity constraints are looking like on the day-to-day. So
Thank you. Yeah, so the other 2 thoughts that we have, and just wanted to, you know, start the conversation here with you all, is potentially changing, like right now our process is a pre-application and application review. And so changing from that process to putting a pre-filled PDF file on the website that's available for download. And basically what that would be doing is would be, it would result in an automatic application denial or moving to the next step, essentially. So if they cannot indemnify the state of Vermont or provide that certificate of insurance or meet any of the other criteria that are on there, these are just the 2 biggest sticking points we've come across. If they can't meet any of those, it results in an auto deny. And the reason that I pose the question here, does this require a data governance council vote, is because right now in the charter, it says that DUA requests are decided upon, the analytics team prepares everything to give to the chair, but ultimately it's the chair's decision. And for the more complex applications, or I won't say complex, more like nuanced applications that we do bring to the DGC, Obviously, you all have heard those in the past, and there's been a vote. So the introduction of this mechanism for receiving applications and having this auto processing step where they are auto denied if any of these first criteria cannot be met, and then they're moved through the process for further consideration if those criteria can be met. So that is one idea that we had in order to, again, reduce the burden on staff and help streamline the process. But thoughts about that, and if you all would agree with that change, if you feel that that would require a vote, and we could do some work to bring some more examples of how we can pull that together at another meeting. Yeah, Josiah.
Do you have a sense of how many, like of the ones that we've done in the last couple of years, how many would be in the auto deny bucket under these changes?
All of them.
All
Do
of
you-
them. Okay, that's helpful.
I can fill in
Sorry, I
So-
was like waiting for Robbie, and he gave a thumbs
lengthier
up.
history. Years ago, I was the chief data steward for the Green Mountain Care Board, and so I processed a lot of these applications. The reason that we do a pre-application is because we don't want a cold application to come in. It is a lot of work, and we would deny most of them. And it's not because we don't like the study. It's technical issues, or we don't have the data. Our data won't answer their question in the way in which, you know, they've proposed their research, or that, you know, there's all kinds of reasons. So we would do a pre-application process to screen out, basically, and really then just work with applicants who we thought had they had what they would need and what we would have to offer to them, like it was a match, and then they could go through the application process. I would say, that said, I don't think this would require a data governance council vote, but certainly open to doing that. But to automate that pre-application process seems like a swell idea, and it would streamline things, and then you would be able to focus on the applications. The Data Governance Council never sees the pre-applications. It would be like an internal staff, like they have the conditions are right to be able to apply, or they're not right to be able to apply. And if they're not, they sort of go away. And then, you know, but it's a lot of labor intensity. The one thing that I would say is maybe just think about if it's feasible for there to be a way for an auto denied applicant to appeal, you know,
Yeah, of course.
and in that case, that might bring it to like application status, which then would be reviewed internally and then by, you know, the Data Governance Council, or the chair, which is the delegated authority for applications.
Yeah, absolutely. There would be an appeal process, and yeah, I think what we would be looking to do, and Kate, I know that you are personally familiar with this because you and I have done this in the past. What we'd be looking to do is remove the hours of work and emails and coordination with requesters who sort of come to us and say, here's my research project. Can you tell me what variables are in the APCD that would help this research project? Get that email a lot. Or I have funding from CMS and they say that I can have a copy of your data. Well, I have a data use agreement with CMS that says you can't. So here we sit at an impact, you know, like, and we get these kinds of requests all the time. You know, I just, as an estimate, Robbie, what would you say, like 10, 15 hours at least per pre-application request of just back and forth, back and forth. Can you have a meeting with that? Can we talk about this research project? What, can I have this variable? Is this like just on and on and on? And so we just want to get a process where people can learn, upfront, that's very clear on the website, very clear in the application. Here's the criteria you need to meet to get through decision gate 1. And then from there, the next one and the next one. And then where applicable, such as data linkage requests, it would come to the Data Governance Council, and we're doing it in an approach that's uniform, more uniform for all the requests. And that's like making things a little bit easier on staff. Robbie, anything else you want to add? Oh, sorry, Lori, I see your hands up.
I'll let Robbie go first.
Nothing to add, Lindsay, like very well made statements. Thank you.
Okay, cool.
So I was just gonna agree with Kate that I don't see the need for a vote, and
Okay.
It sounds like a great idea to have a auto deny kind of a feature. And then I wondered too, have you ever had a kind of like a completely fictional synthetic data set that people can download that gives them a sense of what the data look like, so they can take a first crack and be like, oh, well, this doesn't answer that question at all. My research question.
Yeah, that's a great point. I think the direct answer to your question is no, we don't have anything like that right now. The closest that we have is we have an APCD snapshot on the website, but that's a Tableau visualization of what's in the APCD, not like file structure and size and things like that. One of the enhancements that we are working on internally is creating, I'm just going to call it a table, like a matrix of each of the data sets, public use file, limited use data set, full data set, who can obtain access to what, how long that access takes, the size of the files, right? Like so on and so forth, to kind of help people understand what is in each and follow a path for each as appropriate. Yeah, Wendy.
Just to connect us to some of the stuff that we had mentioned earlier about updates to the website. Another consideration that we're taking, which folks will hear about when we're ready to properly kind of step through it, is there's an awful lot of metadata, like data dictionaries, things like data catalogs. Like there's an awful lot of metadata that could potentially be packaged in an accessible way for the web, and that would be a perfectly acceptable way. Most other states do this kind of thing. A lot of other agencies and departments do this kind of thing in state and federal government, where you push that kind of metadata to the web. So when folks have a question about like, oh gosh, which elements do you have? Like, okay, well, here you go. Like, take a look. There it is. So lots more to come on what the forward-facing presence for this kind of information will look like in the future.
Thanks, Wendy. So then the last bullet point is again, sort of like a discussion or to think about as a group, is exploring more robust public use files for Medicaid and commercial data. Right now, there is a public use file for the APCD. It is not, VUDS itself is also a public use file, but they are not at the same level of observation, and they are similarly fairly easy to get. It's the time that it takes us to receive the request, read it, and then hit send on SharePoint to share out a public use file. But most people most requesters for APCD data really want more granularity and more control in their claims analysis, how they generate the analytic files. And so this is something that we've talked about in the past internally at the GMCB, but how to create more robust, usable public use files for Medicaid and commercial. And what this would do if we had something like this is it would it would be separating out those use cases for people who, or researchers who really do need the entire limited use data set with all of the levels of detail and granularity that there are, and who are okay to engage in that months, potentially year-long process to obtain access to VCures versus someone who has a need for the data quicker, can do with some analytic decisions being made for them in the creation of a public use file. So just wanted to put that out. I don't think that this needs specific data governance, like a vote per se, but just wanted to like put that out there for discussion and for thinking about what might be possible and what limitations we would have on the types of data and the levels of granularity that we can share for that.
Any of the council members have thoughts on that? We do have a public use file for VCures though, right? Yeah.
We do, yeah. It's without getting like too into the weeds, technically, it is one file. And it's great for summary and like descriptive statistics. But the unit of the level of the observation is such that there's not a lot you could do with it, like in terms of like statistical models, or if you came with your own research question, could kind of use that and make it fit into the research question. Yeah. So it has some uses, but generally not. Most researchers are like, no, I really want the full database. Or, you know, it's not the full database, the limited use data set option, which is still a lot of data with, you know, the most detailed like level of granularity of the data that you could possibly get, which is, it's complex and it's not easy to use. And we also often, the GMCB often ends up doing a lot of research support as well, because not, that is a skill set in and of itself. Claims analysis is its own sort of area. And so we end up offering support in that way as well. So if it's possible to generate analytic files that are still meet all of the data disclosure protocols and have all the same protections, but maybe it's a different combination of files with different perspectives so that somebody could use those combinations of files to like get at their research question. So instead of having one file, maybe we have a file that summarizes APCD data at the hospital level. Maybe we have another file that's at the, I'm trying to think, at the CPT code level, in terms of like volumes and things like that. Or we have a diagnosis file, like summary data that's, again, still meets all of the data disclosure like protocols, but that is a little bit more nimble and is not the limited use data set that takes, again, months or a year to obtain. So just some different things that we're thinking about to try to make it easier for researchers and also reduce the burden on us. Yeah, Kate.
I just want to say thanks. I think that's great. That's, you know, step in the direction toward improvement of making data available. I think that the biggest roadblock that you'll have is the small numbers.
Yep.
But I want to say, was it Minnesota that has some great public use files? I remember looking at them, and aside from them having, I don't remember if it was Minnesota or not, but you're nodding your head, so maybe that's right. If
Yeah,
you,
There's
if
Minnesota.
those of you who are interested, you could look up Minnesota APCD public use file, and you'll probably find it pretty quickly. But they, in addition to having different data files that are available, I remember really liking their streamlined process. So the public use files are preloaded on the web somewhere in a secure space, but you go through the kind of like an application process to access it by, providing your name and contact information and maybe the purpose of the use of the file. And then you, so you go through a couple of gates and then you can just download the file. So there's never a time when you're interacting directly with a human, staff person requiring time and intensity and things like that.
Yeah.
So I remember really appreciating that system that they had. Just mentioning.
Yeah.
And Kate in the chat, for the record, she said Washington State also.
Oh, yeah.
Washington
Okay.
does.
Great. Thank you, Kate Davis.
Thank you, Kate.
Great. Well, thank you, Lindsay and team.
You're welcome.
Really thorough updates. Lots of food for thought here. I did look up the next meeting just for the record. It's October 7th. So some of these things we'll come back to then when we're ready. But the staff will be working on charter changes and some of these other recommendations. It was a really good discussion. Thank you, council members, for your input.
Yeah, thank you.
Thanks. So the next item on the agenda is new business, and I want to make sure she's on the line. Emily Brown is on the line now, and I wanted to just turn it over to you to introduce yourself. I introduced you briefly, but I think you can do a more thorough job about some of the work you've done before coming here to the board.
Oh, thanks, Susan. Hi, everyone. I'm Emily Brown. I'm the new executive director at the Green Mountain Care Board. Yeah, it's really interesting being on this call because previous to joining the board, I was at the Department of Financial Regulation as the deputy commissioner there of insurance. So we had several projects where we were reaching out to probably Kate and her team, and I think we had talked to Lindsay as well about accessing data for whatever research project or assignment we had. So this is really interesting to see kind of the behind the scenes work and all the effort you all put into this. It's really amazing. So prior to this, as I said, I was the deputy commissioner. I definitely always seemed drawn to the health insurance side of things. I think it's, one of the most interesting parts of the insurance world. And then also, with that leads to healthcare. So I'm really excited to be here and to kind of see all of you at work. And I'm sure I'll get to know a lot of you as well. I'll probably be popping into this meeting, but I believe, and Susan, I'm not sure, I missed the beginning of the call, so I apologize. So I don't want to speak out of turn, but I believe there'll be an adjustment of leadership in this meeting. Okay, I see Susan nodding. So, but yeah, but I am happy. Please reach out if you have any questions or want to chat with me. Yeah, thanks. Thanks for the intro, Susan.
Thank you. Welcome, Emily. And I did skip over public comment, so I'm going to reverse and go to public comment and open it up to anyone on the line who wants to provide any public comments on our discussion today. Okay. Does the council have any, I added the new business with Emily. Any other new business from the council members? And any old business? Okay, do I have a motion to adjourn?
So moved.
Second.
Goodness. Thank you, Lowry. All those in favor? Say
Aye.
Aye. Thank you all.
Bye-bye.
Bye.
Thanks, everyone.